Hello, everyone, and welcome to today's webinar, Dueling Visions of Healthcare. What should the aging philanthropic community pay attention to? Before we get started, I'd like to go over a few things so you know how to participate in the webinar today. When you joined the webinar, you selected to join either by phone call or computer audio. If for any reason you'd like to change your selection, you can do so by accessing the audio pane in your control panel. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time. We will collect them and address them during the Q&A session at the end of the presentation. I would now like to introduce John Feather, CEO of Grantmakers in Aging and moderator for today's webinar. John?
Well, thank you so much, Joy, and I'm delighted that so many of you have decided to join us today. It's been a tumultuous couple of weeks here in Washington, and we're looking forward to learning more. Before we begin, we want to thank West Health, whose support allows us to offer this webinar series free of charge to all of our members. As you know, this is a time of rapid change in Washington, and programs in aging are part of that change. Here at Grantmakers in Aging, as a nonpartisan organization, we want our members to have access to the most accurate and up-to-date information from Washington outsiders who have a deep knowledge of programs on aging and how philanthropy can be impacted. So we're very grateful once again to West Health for their support in allowing us to provide this monthly series to our members. We're also extremely pleased today to have with us to discuss these important and complex issues, Chris Jennings. He is a fellow of the Bipartisan Policy Center and has over 3-decade-long health policy work, including at the White House, the Congress, and the private sector. Mr. Jennings is currently the president of Jennings Policy Strategies, a nationally respected healthcare consulting firm committed to assisting foundations, purchasers, health systems, and other stakeholders to develop policies to ensure higher quality, more affordable, and sustainable healthcare. As was mentioned, you're able to enter questions during the session, then we'll turn to those at the end in our Q&A. Just open the box in the control panel that you see on your screen that says questions and type in your questions, and I will be asking those of Chris later on. So Chris, welcome.
Well, I'm sorry for the delay. I had myself on mute, John, and I'm happy to be here with you and everyone with Grantmakers on Aging.
Well, thanks so much for being with us. Let's start with an interesting day we had here in Washington a couple of weeks ago, where we had two groups of senators holding dueling press conferences on the same day to talk about two really radically different approaches to the federal role in healthcare. One was the Medicare for All or universal healthcare approach that has probably been most identified with Bernie Sanders, but obviously many other people as well. And the other was basically to take the federal role in healthcare, and particularly the federal funding in healthcare, and roll a lot of it into large block grants towards the states. So I know that you paid a lot of attention to those both those conferences. What's your take of these two approaches and why they seem to have emerged as the ones we're talking about today?
Well, thank you for that question. It was a very interesting day, and it's probably notable that the media coverage of that day seemed to focus far more on the single-payer Medicare for All than at the time, the Graham-Cassidy bill. And that's maybe largely because there was sort of a sense that the Graham-Cassidy bill might not move that quickly, and yet it was in the middle of a major attempt to pass the Senate. That it was quite clear they were very, very close, and as you know, there have been multiple attempts by the Senate to pass a repeal and replace of the Affordable Care Act. which ultimately was the objective of the Graham-Cassidy legislation, and to replace it with, as you mentioned, a very large block grant which folded in all the new Medicaid and the exchange subsidies to be distributed amongst the states, but then constrained the growth rate and cost allocate or the funding allocation to the states, and then reallocated amongst and between the states, largely from those who had expanded Medicaid coverage to those who had not. And so you had a real debate about this issue, really, of federalism. You had a single payer, which really, and Medicare for All, which is basically folding in all but Veterans Affairs and Indian Affairs into one program, including, by the way, the current Medicare program, and substantially increasing the benefits, lowering cost sharing, and making it available to all Americans, which would certainly be a very, very nationally oriented, federally oriented approach. And the converse was basically leave it to the states with a lot of flexibility on how to administer the program, but also with a lot fewer resources to do so. Ultimately, as you no doubt have seen and read about and seen on TV, the Republicans were once again unable to get the majority votes they needed, the 50 out of their 52 Senate votes necessary to bring up this bill and pass it. Different people will tell you that they had between 40 and 49 votes. But ultimately, the Republican Party at this moment in time has continued on sort of a partisan approach to deal with this, and therefore kind of presumes that the Democrats will not vote for it. And it's a very, very narrow line to draw, and that's what helps explains why they consistently and continually seem to fall a little bit short. So, but it got a lot of attention. This state-based approach, the state-based flexibility approach with less resources, is something that will not go away. This, unlike maybe some of the other Republican proposals, this was not voted on. It will be worked on further. Senator Cassidy has indicated his interest in continuing on in this debate, and others have indicated the possibility of legislative vehicles to do so. So while this fiscal year, ending October 1st, will conclude with no repeal and replace the Affordable Care Act, it does not in any way suggest that the effort will not continue.
Well, let's continue on that a little bit more. So I think there was some sense after the bill failed earlier, not Graham-Cassidy, but the previous incarnation of it, that we were done, and that this effort to abolish Obamacare or the Affordable Care Act was over. Well, of course, then we came right back into it with Graham-Cassidy. So how do you see that working? Do you see it attached now to other bills? Are there other opportunities that can be used to move this forward? Would it be this whole piece of legislation, or just smaller chunks? How do you see that happening in the coming months?
Well, of course, the main immediate attention that people are now focusing on is what is going to happen with the Affordable Care Act as is administered by the Trump administration, and the degree to which there will be additional problems in terms of premium increases, overall affordability, the ability for older populations and others to purchase, for example, as well as a debate around whether the Congress can work in a bipartisan way to make some modifications to the current law and its implementation to ensure an adequate funding stream and more affordability and sustainability. There is an effort by Chairman Alexander of the Senate Health Committee, a Republican from Tennessee, working with Ranking Democrat Murray of that committee to see if they can develop a market-oriented approach to strengthen the insurance market by providing explicit subsidy funding through the so-called cost-sharing reimbursement subsidy. This is a subsidy payment that helps keep premiums down and also keeps cost sharing affordable for lower income people. And to date, the president has not given a commitment that he will continue to fund that payment. And as a consequence, insurers have been asked by the majority of state insurance commissioners to presume that that payment will not be made. And as a consequence, this fall, we're already seeing premiums that are 10 to 20% higher than they otherwise would be. So that is sort of a here and now impact. The question is whether Congress can pass something still to in any way impact the 2018 premiums, and it will be too late probably early on, but if they do pass it, they can probably mitigate the impact later on. And whether or not they will pass legislation to make clear that this will be a permanent or longer-term authorization that plans can rely on for their decisions to participate and set their premiums. This is just a hugely important issue, and we'll have to see what happens. But as we talk today, I have to say that it's going to be very hard after a very, very partisan fight to see everyone come together. There is some hope that it could happen in the Senate. It appears like that's going to be difficult, but not as difficult as the House, and also getting an agreement for President Trump to sign this bill. But that is out there, as is, by the way, sort of an immediate issue that is important to older people because they care about their grandchildren, is the reauthorization of the Children's Health Insurance Program, which is set to expire on October 1st as well. And that, too, in this sort of partisan environment, is tending to, even though it's a very bipartisan law, is tending to get delayed as well, maybe as late as December. So, but all these things are quite critical. Now, the last question you asked is the repeal part of this debate over? You know what? I really don't think it is. I think that many members have made promises and pledges that they will continue to work to try. And it's very possible that certainly after any resolution of a tax bill, which we should talk about, and its implications, there may be another reconciliation bill that goes straight to another repeal and replace effort right before the 2018 election cycle. So, you know, you can't rest easy. You never can when you're doing healthcare. That's why I call healthcare reform almost full employment, because there's always something going on.
Well, you know, I think one of the important things in terms of all this is looking at the basic structure of how things work in Congress in terms of the procedural stuff. I think it's been, for me and for many people, a really interesting reminder of high school civics, probably advanced high school civics, about how this all works. So, you know, maybe a little bit of background around that. So this is not something that they could just attach the you know, Affordable Care Act repeal to the defense bill or the highway safety bill or some other thing that everybody's for. What are the pieces that are required to do something like a repeal and replace procedure in the Congress?
Well, I mean, of course, you could attach anything to any piece of legislation, but usually it would be without the reconciliation protections. And the reconciliation protections, normally in the operations of the United States Senate, in order to proceed and pass a piece of legislation without objection of the minority party, or with just limited objection of the minority party, you have to secure 60 votes. And there are all sorts of rules governing the Senate process on this, but as I've mentioned, the Republican Party has 52 votes, which means that they cannot pass pieces of legislation outside the context of so-called reconciliation budget instructions without a 60-vote margin, because the minority party can object, can extend debate, and they will not be able to successfully file cloture, particularly on non-budgetary items. And so the reason why the Republicans in the House and Senate followed the reconciliation process this year is they felt and concluded that Democrats would not be cooperative in their attempt to repeal and replace the law, which is true. They were hoping for more of a repair debate as opposed to a repeal debate. And so they saw their only avenue being passing a reconciliation that would allow them to pass the bill with just 51 votes, in essence, with the vice president being able to cast the tie-breaking vote. And even under those, and particularly under those instructions, when you craft that legislation, it really has to be policies that have a direct budgetary impact, because the reconciliation instructions are given for the annual budget process. So as a consequence, it became even more complicated for Republicans, because they couldn't modify the laws related to some of the health insurance reforms that they wanted to see, like across state lines, purchasing, etc., without a 60-vote point of order they'd have to beat, which they would not have gotten from the Democrats in the Senate. So they had to construct their bill accordingly. So it's a long way of saying that you can do it really two ways in passing legislation these days. You can do it bipartisan, and bipartisan has the advantage not just of a sort of a public messaging, but it also gets policymakers from both parties invested in the underlying legislation and ultimate law, which allows for its sustainability and easier care and maintenance improvement and reforms over time. For the reasons I've laid out, that was not going to happen this year. And so the other option is this reconciliation, sort of a jamming approach. And in this case, not only did they decided to bring it up with all but one hearing and no formal markups or amendments permitted, which made a lot of people quite nervous. So that's why we are where we are. I think we will continue to be in this dynamic until and unless President Trump shifts course and says he wants to work on a bipartisan basis on health reform. We all know by watching President Trump that changing his mind or changing directions is possible, so we always have to be on our toes.
Let's talk a little bit about the two specific approaches in a little more depth. I think people sometimes assume they know what universal health care or Medicare for all really means, but this was, as discussed in the press conference, it was interesting to see the pieces that were talked about, particularly how it would be ramped up. I mean, this would be an enormous, this would be the biggest change in American healthcare ever, and including how you actually get people into the system and when it would happen. If such a thing were to pass, do you think it really would be possible to include people in the system basically over a 5-year period, and in big chunks, people in a 20-year age group and then the next 20-year age group until everybody's ending up
Yeah.
in it. And
Well,
I guess the other question really is, older people and people with disabilities are obviously the focus for Medicare at this point. There's obviously some other groups included. Could this end up weakening the work that Medicare does for older people and people with disabilities by having everyone in it, or is it likely to strengthen it politically?
yeah. Well, all very good, fair questions. Um, I think there's anytime we're looking at any major piece of health reform, I think that there's an understandable degree of nervousness. Healthcare is the most personal issue that any of us have, and as a general rule, the country does not have a lot of trust and faith that the federal government necessarily will do something great for them, and they tend to fear that it could result in loss to them. And in fact, we've sort of seen that with the debate around the Affordable Care Act. We saw sort of a attempt to pass legislation that relatively narrowly targeted a population of people who are uninsured. It did impact everyone, but primarily it affected a large population of the uninsured. But one of the greatest concerns that people had was disruption to what they had and costs that they were paying out of pocket. And I think we saw that debate come, and it was very, very difficult, and the implementation was very, very difficult. And then once it got into place, and people got used to it and saw its role and the protections it provided, they tended to be more supportive of the underlying legislation, not at the time of passage or implementation, but by the time as the debate started around repeal and replace for losing something. And I think similarly, we'll see that with regard to anything called Medicare for All, although this would be, to your point, much more substantial, would require a much more significant transfer of private to federal dollars, potentially much greater disruption because, as you know, most people who are working today get their care through the employer-based system, and it's generally fairly popular. So this is going to be a very, very tough nut to crack and to transition from a policy and a political perspective. To the point about seniors and older Americans in general, what they really quite love their Medicare program, and they're concerned. Their general instincts around this is some concerns that if it gets broader, will it weaken the program? Will they be more vulnerable over time? It kind of comes down to whether you resource these programs adequately. Senator Sanders has indicated that he's not only going to give the Medicare population their current benefits, but he's going to expand them, notably, so much so that some seniors would choose not to buy or would not be necessary to buy Medigap policies. So the array and range and scope and depth of benefits would be far more generous. How that works in terms of financing with the current Medicare trust fund and payroll taxes and funding to the payroll taxes, and how elderly are treated relative to other populations within the Medicare for All vision, really has yet to be fully at least digested by me, or I think fully thought through by the bill sponsors. And I will say, that with the two barriers, I think being, well, maybe three. One is fear of disruptions to the employer-based system, fear of disruption in negative ways to the Medicare program and its beneficiaries, although that can cut certainly in both ways very positively too. And then third will be this whole debate about financing and whether the public is comfortable with having really all choices being limited to Medicare, and also whether they're comfortable with the financing bill that comes along with that. And so I think this has a ways to go. I think the reason why it's gotten a lot of attention is because the public is increasingly concerned about the lack of responsiveness the healthcare system has in terms of probably two primary issues. One is out-of-pocket cost, which they see is increasing more and more, particularly with regard to prescription drugs, and complexity and their experience with the healthcare system. And so, in my view, whether it's the public sector or the private sector, they're going to have to be responsive to that need. I hope that's responsive to your question.
Absolutely. Let's take a short look then at the other major approach, and particularly one of the things that those who work in aging have focused on in terms of some of these different block grant kind of approaches, which is the potential that it would also include large cuts to the Medicaid system. So the Medicaid system obviously is most visibly important to older people in terms of its impact in long-term care, particularly support for nursing home patients, but obviously fits into lots of other pieces in the system as well as providing for other people who are unable to afford health care otherwise. So are those things, are block grants and cuts in Medicare and Medicaid specifically, are they inevitably tied? How do you see that rolling out? If we block grant to states, what do you see as the impact for the programs that mean the most to older people?
Well, states and governors always like more flexibility to administer a program, but and they're not as concerned for a national basic standard in all cases, because they think you can do things more creatively closer to the people. That is always sort of part of the debate, but any governor who has administered the Medicaid program knows that the bottom line is the bottom line, which is the financing. And really what block grants and per capita caps are used to do when they're used, because they're only used for this purpose, is to reduce and limit the amount of dollars going to the states. So in other words, significantly reduce the allowable rate of growth in the programs at a time when, as you know, the baby boom population is aging through our whole national population. Baby boomers all started turning 65 in 2011. In 2021, we will see the first of all the baby boomers turning to 75. And ironically, the first cohort, the 65 to 74-year-olds, are actually pretty healthy and have helped suppress the rate of growth in the Medicare program. But as you get older and older, that's going to have a real big impact. And you can imagine if you block grant or per capita cap the Medicaid program in ways that are designed to get significant federal savings precisely at the time when you're going to have more dollars being required to spend for those populations, it's very, very disconcerting. It really ends up being little more than a cost shift. It's not really cost containment. It's shifting cost and risk to the states and then ultimately to some of the most vulnerable populations that we serve. So ironic, one of the reasons why they had a hard time passing this legislation is that there were a number of Republican governors who had expanded Medicaid, and even others, who were quite concerned that the magnitudes of the cuts would be something that no amount of flexibility could make up for, and that's really that's the onus of, that's the rationale for this debate. And of course, the reason why you have to watch every debate in Washington is because every debate is ultimately related to health care. And why is that? It's because healthcare makes up such a large percentage of our overall federal budget between Medicare and Medicaid, and it will be increasing over time. And when you have higher and higher deficits or debts, there'll be more and more pressure to cut those programs. And this was an attempt to do just that, but make the states be the entity to administer the cuts, not the federal government.
You already talked a little bit about the generational shift with the boomers and so forth. One of the groups that we don't hear as much about, but I think some folks are particularly worried about, is the people right below that age group. So the people that are now in the 50 to 65 year range who are not eligible for Medicare, and therefore do not have, when they lose insurance through their work-based insurance, for example, really have a hard time. What do you see happening for that group? Is there anybody stepping forward with legislative proposals in that arena?
That's a great question. Part of the reason why the repeal effort did not succeed was that one of the stakeholders who was adamantly opposed, in addition to the heart cancer, diabetes, all the major branding patient disease groups, was, of course, AARP. AARP raised the question and the concern that that the repeal of the Affordable Care Act and its replacement would substitute an allowance for insurers to be able to charge 5 times as much for an elderly person as a younger person, as opposed to 3 to 1 as it is under current law under the so-called age rating. They labeled that an age tax. And it was quite a compelling argument for those 50 to 64-year-olds who already are facing fairly high premiums to purchase in the marketplaces. For those people who have to, if they're not in an employer-based system, which many of them have retired, or they're not eligible for Medicaid, and let's say they have incomes in excess of $50,000 and they're individuals, they're not eligible for subsidies. And the consequence of that is, as we see more and more sort of efforts or outgrowth of sort of mismanagement of the exchanges, some people call it sabotage of the exchanges, but you can call it mismanagement or sabotage. And what you see is that premiums are higher than they otherwise would be. And the consequence of that, particularly for an older person, is they're not only facing even the allowable age rating bands, but no subsidies and much higher premiums. And this is a population that I think Republicans and Democrats should care quite a bit about, and why this fix in the cost-sharing payment that I referenced earlier is that Senator Alexander and Senator Murray are pushing for is so important, because if we don't see that, we will have locked in much, much higher premiums and much more difficult access to needed health care for that very population, 50 to 64.
Right. I'll ask you one more question from my list, and then I'll turn to the questions from the audience. So to remind everyone, if you would like to ask Chris a question, we'll be doing that immediately following this. You just go to the control panel that you see on your screen, and you open the question box and type your question in there, and I'll be asking those in just a moment. So at this point, one of the things is some people think, well, we're done now with healthcare, so now we've moved on to tax reform. And obviously that's a major issue that we're hearing a lot about, not a lot of specifics yet. What do you see as the relationship? As you've already said, all this stuff is related. So what is the relationship between the kind of tax reform or tax changes that have been proposed and the healthcare system, particularly as it relates to older people?
Well, the question about the tax reform has been raised and is not yet resolved, but certainly, again, the Republican leadership has chosen not to do this in a bipartisan way, so they're going to do tax reform in a new reconciliation package of instructions that give them the protection and the authority to pass something with 51 votes. And there are some people who were part of, including Senator Graham, who were part of the attempt to repeal and replace the Affordable Care Act, who are now advocating for the instructions to include the ability to integrate another attempt to repeal and replace. And that is a vocal and loud minority of Republicans who are pushing that, but it's out there and it has to be watched, as does any type of modification to the reconciliation instructions that might allow for some backdoor Medicaid cuts to be used for offsets to pay for these tax cuts. Because what's quite clear is that the tax cut proposal that the President Trump has just sort of unveiled, and details to follow, almost inevitably will increase the deficit. And some of the budget hawks might insist on Medicaid being an offset for that policy. I think that's lower than likely, but it is not impossible as a possibility, as is it's lower than likely that they'll include specific instructions on a broad repeal effort, but that's still possible. But this is the reason why I mentioned it, and particularly Medicaid. It seems to be the whipping boy, the safe place to go for many of the Republicans, and even if they don't include it in this package, what you could see, of course, is the deficit goes up, and then the deficit hawks have yet another argument, largely because they've just created one, to further cut health care programs, in particular Medicaid, maybe Medicare, but definitely Medicaid, to help reduce the deficit after they've just increased the deficit through this tax cut bill. So it's a very all this is to the point. And by the way, same type of pressures. If we suddenly have a pivot back to the desirability to address deficits and debt, then you could see really important programs like Old Americans Act and all the associated programs, Meals on Wheels, etc., be vulnerable as well. So yes, there is never a major debate, particularly relating to dollars, that does not have a direct or indirect impact on health in general and aging interests overall.
All right. Thank you so much. We'll now turn to some questions from our audience. And this is a couple questions came in about bipartisanship and bipartisan approaches to healthcare. Is it simply unlikely that we're going to see anything in this direction in the next foreseeable future? Or basically, have we poisoned the well to the degree that it's not possible? And I think one of our questioners asked a specific question: what if one of the two sides of Congress flips over to the Democrats, that either the Democrats take over the Senate or the House? Does that make it more likely that we will see legislation that's passed on a bipartisan basis, or is it just so difficult at this point that we're not going to be able to move forward?
Wow. Well, very thoughtful questions. Well, first, as you mentioned, John, at the beginning, I have been involved with the Bipartisan Policy Center since its inception years and years ago by Senator Dole, Senator Baker, Senator Mitchell, and Senator Daschle, all former leaders of the Senate who have been and continue to be committed. Senator Baker, unfortunately, has died, to create an environment for a bipartisan dialogue on a range of domestic and international healthcare or health issues, domestic issues and international issues, including healthcare. And I've had the good fortune of working very collaboratively with Republicans and Democrats to begin to try to foster safe meeting places for people to have those discussions and policy recommendations that people on the Hill can utilize. And indeed, we've made recommendations that would be very consistent with the bipartisan efforts by Senator Alexander and Senator Murray to sustain and stabilize the insurance marketplace, and they're working very diligently to do that. I mentioned earlier that the politics and the process and the timing create formidable barriers to that, but they're not impossible, and they should work to try to overcome them, and we're doing everything possible to do that. In terms of what happens, though, I mean, it obviously is very partisan with a only Republican control over the House, Senate, and the White House, and the consequence of that is that a lot of times the leader, whatever party's in power, tells the incoming president, those other guys will never be with you. You've got to be with us. And we're your party, and ride the horse that you came in on. And that's very appealing to do, particularly when you feel like the other party is hostile to your agenda. And the problem with the Republicans in the last few years is they have sort of a divided party, and so it's hard for them even to find consensus. And so, yes, I'd answer the question that if there was split government, if Democrats controlled one or both houses, almost by definition, the president would have to work on a bipartisan basis to get things done. And sometimes it seems that split government allows, in fact, necessitates that type of collaboration that can be sustainable. And we've seen that in the Social Security Act amendments of 1983, in a whole host of other major reforms in the past, Balanced Budget Act of 1997, where one party was in the White House and the other party was in the House and or Senate, and you got major things done, and major things done that were sustainable over time. The Children's Health Insurance Program is another example of that. So, good question. I think sometimes split government does allow for that. It doesn't necessarily guarantee it, but it certainly enhances the likelihood that it will happen.
Well, a couple questions then about the part that you just mentioned, which is the role of the current president in all this debate. So far, the discussion of his role seems to have been primarily around the repeal and replace legislative attempts. Do you see places either from the president himself or from his administration that would allow ways for us to move forward on something that is not simply wipe this away and start over, or is it just going to be rigidity for the rest of the term?
Well, that's largely up to him. You saw sort of a bipartisan agreement around the debt limit earlier on in this year, and suddenly things were possible. And by all reports, the president was pleased to see his polling numbers go up and his impact increase when he did work with Democrats, much to some dismay of some in the Republican Party. But notwithstanding that as somewhat of an outlier this year, there's always that chance. There always is that possibility. Certainly is always that opportunity. We'll be getting closer and closer to the 2018 cycle, the reelection of the Senate and the House, and you never that sometimes as you get closer and closer and farther into the election cycle, things sometimes become even more difficult. But no, I remain hopeful that can happen. I did want to mention that as much as people focus on bipartisan activities or partisan activities in the Congress, there tends to be a lack of focus or understanding of the power of the executive branch to administer, to interpret, to enforce the law, and those powers are pretty substantial. And we, in healthcare world, they're usually done through waivers or other such interventions, or even sometimes just through guidance, regulatory guidance, even FAQs, which is a term for frequently asked questions, may sometimes just change policy. And one bit of advice of people that I tell the people outside of Washington to think very, very carefully about are the positive and negative impact and implications that sort of unchecked, unbridled, or just go at your alone regulatory administrative actions can take. And we just heard today of some interest in pursuing something potentially on selling products across state lines or setting up association health plans. These could have enormous impacts on insurance pools and marketplaces in state and local levels. So one, I'm not sure you asked me this question, but I want to make sure I don't let us go without underscoring the imperative of watching the executive branch wholly independent of its interactions with the Congress.
I think it's an essential piece, and it's also true that I think in the healthcare arena, as well as the aging-specific programs, we are continuing to be somewhat concerned about truthfully, just the lack of leadership there. There's a lot of vacancies still in the senior positions, and it's not clear how things are getting done. I think we have time for one more, then I'm going to ask you to wrap up at that point. So the question is, we've had a very interesting time in the last couple of weeks here in Washington. Is it likely now, several months before we're going to have another major push in any direction around legislative activity in this area? So what do we need to be doing in philanthropy at this point to pay attention to the right things?
Well, I think in terms of the congressional, you're looking at legislative vehicles. You're looking at the next reconciliation bill. You're looking at any type of ongoing appropriations process, continuing resolutions. You're looking at the Alexander Murray insurance reform policies and any vehicle it can be attached to. You're looking at the Children's Health Insurance Program, because they will be included upon that reauthorization will be some Medicare reforms that they're called the extenders. They tend to be extending policies that were permitted previously, and there's some provider and some beneficiary interest in some of those. You're looking, as I mentioned, about the tax bill and its implications, either short or long term, as it relates to the Medicaid program. And finally, as I mentioned also, you're looking at administrative actions that could create dynamics that could be positive or negative from your particular interests, but some of these dynamics of association health plans or across state lines occur, you could see a lot of pressure and a lot of new avenues for certain health plans to, in essence, medically underwrite populations, provide fewer benefits, avoid older, sicker populations. And I would argue very strenuously that that's an area that could be one of the most important immediate threats. So most definitely a lot to do. I guess the last thing I would say, I know I'm giving you too long of a list probably, but is the interactions between the federal government and the states as it relates to potential waiver authority in the Affordable Care Act, and what Secretary Price, notwithstanding his current problems of the day, and the CMS Administrator Verda do in collaborations with the states. So all these issues are pretty much here and now, and I would probably doing you a disservice if I didn't highlight at least, a sampling of them.
Well, thank you very much. At this point, I'd like to ask if you have final words of wisdom for our audience before we let you go.
Well, I was really happy to have an opportunity to talk to you all. My first job in the Senate for 10 years was working on the Senate Aging Committee as the Deputy Director for 3 senators. And I have to say that it really was a great a learning platform to see the breadth of issues that older Americans both face, confront, and have opportunities to address and empower themselves to address. Everything from income security to health care to housing to social services. And we are about to go through this aging boom where enormous scrutiny will be placed on how much money we are spending out of our total budget on income and health care payments. And my view about that is going to be that we're going to have to, and this is before, by the way, we've talked about either single payer or talked about long-term care and the great needs that currently exist. I would just urge us all to recognize that we're going to have to be a little bit more proactive on both ways to get better returns on our investment. So cost containment to sustain the populations that we're committed to serving, as well as to recognize that over time there's going to be a need for greater revenue to help offset the cost of this population in need. And no one likes to talk about either one of those issues. Taxes or cuts or cost containment, those aren't fun. But we will be kidding ourselves if we don't fully recognize the level of attention and scrutiny those policies, those issues, those people we all care so much about will undergo. And if we aren't a little more proactive at designing the best ways to do that, as opposed to letting others do that, then I think, 1, shame on us, and 2, we won't be happy. Will that happen tomorrow, the next day? Not necessarily. But it's not too far down the road. Just Look at the demographics. Look what happens in this country when we have these demographic explosions. Meaningful things happen. So I hope that's not too much of a downer. I think that's my view, is that's an opportunity as well, an opportunity for engagement, understanding, information, research, polling, all sorts of things. And so, whether it's short, intermediate, or long term, you two are all going to be in business for a long time because you're doing great things and you have a lot of potential to do a lot more. I guess I'll conclude on that if that's good.
That's good. And great words of wisdom for all of us. I want to thank Chris Jennings for his participation in today's program and thank him and all of his colleagues for all that they do to make life better for older adults. I also want to thank West Health for their support of this webinar series, which allows us to provide it free of charge to our membership. We will be making a recording of this interview available to our members, so watch for an email from us to be sent later with the link to the rebroadcast. Our next policy webinar will be on Tuesday, October 10th from 2 to 3 p.m. Eastern, entitled Medicare, How Safe Is It? And will feature Dr. Judith Fetter, the Professor of Public Policy at Georgetown University. Please watch your inboxes for the registration information. And finally, I want to thank all of you for participating in today's webinar. Have a great day.
Thanks, John.